All right, welcome to the Kansas City Quality Value and Innovative Consortium Forum. Our vision is to bring multiple stakeholders together to improve the quality and value of healthcare in the region. KCQVIC is supported by our partners BioNexus KC, UMKC NextGen, and KU Frontiers Clinical and Translational Science Institute. We need to find ways to deliver better care at lower costs to achieve better health care for patients and populations here in Kansas City and in the region. That is our triple aim for Kansas City. The Kansas City QVIC activities to date have centered around 3 key activities. Our first area focuses on regional quality improvement projects. To select these projects, we did a lot of analyses and collected input from stakeholders to better understand the priorities in the region and to identify topics that would allow us to implement initiatives and evaluate the outcomes of these evidence-based strategies across multiple hospitals in Kansas City and a number of other stakeholders. Ultimately, we settled on 2 different projects. The first is Kansas City Epic, which is our opioid project, and we have 8 hospitals participating in that project here. Second is our Transitions of Care for Heart Failure project. This project focuses on social determinants of health, and we have 11 hospitals that have expressed interest in that project. In addition to these regional quality improvement projects, where we're helping to implement and evaluate the success of them, we've also developed the TIARA program, or Training and Implementation Actionable Research Approaches. This program educates investigators, quality improvement personnel, and others about implementation and methods behind implementation. And finally is the Kansas City QVIC Forum, which is what you're here for today. It's a strategy for engaging our communities and stakeholders through the dissemination of information that is important to you and provided by members of our community. We finalized our agenda for 2021. Next month, we'll be discussing strategies for healthcare provider change on May 13th from 3 to 4:30. And all of our forums will remain virtual until it's safe to hold these in person again. You can register on our website, just as you did for this forum, at kcqvic.org. Today, we're talking about isms, phobias, and microaggressions in healthcare. We have an excellent lineup today. I, Christina Pacheco, am an implementation manager and manager at St. Luke's Hospital. I'm responsible for the welcome and overview. We'll have Sandra Thornhill from Usazi Village, Carmen Parker Bradshaw from Blue Cross and Blue Shield of Kansas City, Frankie Barrera from Thrive Health Connection, Dr. Megha Ramaswamy from the University of Kansas Medical Center, and Dr. Michael Weaver from St. Luke's Health System. So growing up in the United States, many of us have absorbed considerable misinformation, specifically negative information about people who are different from us and our families. We have been imprinted with negative beliefs, prejudices, stereotypes, and groups of people we barely know. This typically began to happen when we were young and when we couldn't distinguish between truth and stereotype before we could recognize misinformation or object to this information. These assumptions can harm the interactions we have with others in healthcare settings, as well as in our everyday interactions. A lot of research exists as to how isms and microaggressions contribute to inequities experienced by historically excluded groups. Just some basic definitions so that we have a starting point for today's discussion. Isms are a form of oppression. Common isms that we may recognize include racism, sexism, ableism, ageism, heterosexism, and classism. Phobias are an irrational fear of something. For our purposes, we'll focus on homophobia, xenophobia, Islamophobia, etc. These terms or phobias are generally problematic for reasons that go beyond the scope of my introduction here today. But if you want to discuss that, I'm happy to talk about that with anybody. And then microaggressions are everyday slights, indignities, put downs, and insults that people of color, women, LGBTQIA2S populations, or those who are marginalized experience in their day-to-day interactions with people. They often appear to be compliments or a joke, but contain a hidden insult about a group of people. One example would be telling a person of color or someone who is a foreign national. Wow, you speak very good English. So let us get started with our presentation from Carmen Bradshaw. She, will be providing a payer perspective entitled Microaggressions, Deferred Care, and Unequal Outcomes. Welcome, Carmen.
Well, hello, everybody. Can you guys see the presentation?
Yeah.
Wonderful. Okay. It is not working on my end.
You may have
Is it okay now like this? Even though it's smaller, would this work for you guys?
If you go into, if you click from beginning, what happens?
It takes over all of my screens, which I need my notes. Let's try one more time. It does this, but I am not.
Yeah, we can see your notes too.
You have two screens, Carmen.
I do.
Okay,
You guys picked the wrong person to try and start this.
Click display settings at the top.
Okay.
And then swap presenter view and slideshow.
All right. Does that work for you okay?
Perfect.
Okay, I still need to make it a little bit smaller. I hope you can see it okay. Otherwise, it takes over my secondary screen for some reason. But I'll go ahead and get started. I hope you can see okay. I'm going to talk a little bit today about microaggressions, deferred care, and unequal outcomes. And to give you a little disclaimer, I'm very passionate about community health, health equity. I think it's important that you know I'm not a clinician, that I don't really have lived experience with racial equity, that I am still learning very much, and welcome your thoughts and corrections as I work through these learnings myself. I think this is a really important area of work that we all need to feel transparent and honest with each other on. And this may feel uncomfortable, perhaps, not knowing who all is with us today, but I think that that's important. And I think the only way for us to really have good conversation on this topic is to handle those uncomfortable topics. So Christina was kind enough to kind of give us a little bit of a refresher on discrimination, but first I just want to say that isms and phobias are discriminatory. They're often hostile as well behaviors that are based in stereotypes, fear, and ignorance. And we can look at systemic and institutional discrimination, interpersonal, which honestly, this is where I see microaggressions fitting both in the literature and in some of the work I've done in healthcare, where those actions or inactions, whether intentional or unintentional, lead to unfair treatments or mistrust between a provider and a patient seeking care. And it can also be internalized, which is really resulting from both that institutional and interpersonal type of discrimination. When we talk specifically about microaggressions, we're talking about brief interactions that, again, whether it's intentional or unintentional, they communicate negative exclusionary messages to either targeted individuals or groups, and it can be additive. So for example, we could be talking from a racial perspective about, let's say, Black Americans, but you can also further classify that by people who are overweight or who fall into any kind of category that we choose to put them in. There's micro assaults, which are deliberate, micro insults, which are intentional or unintentional, and they really demean someone's social identity. And there's micro invalidations. And these communications invalidate the importance of the person's identity. So let's talk a little bit about why microaggressions matter to health. So these are subtle, often unconscious, and well-meaning people sometimes take these actions. I'm sure that I have taken those actions many times prior to my own learning in this space, not even realizing it. The problem is it often leads to rumination, and it can lead to chronic stress. And what happens after that chronic stress is a significant impact on relationships between a patient and a provider, and it can really affect institutional culture, particularly in a clinical care setting, how both care is perceived to be delivered, but also providers or staff who are involved in care delivery, what is perceived to be acceptable or unacceptable. And this can become a significant contributor to poor health outcomes, from the patient standpoint, clinician burnout or staff burnout from the provider standpoint, and ultimately it leads to medical mistrust. You know, it's been 15 years since the publication of the Institute of Medicine's Unequal Treatment Report, which synthesized a wide body of research that demonstrated racial and ethnic minorities are less likely to receive preventive medical treatments than white Americans, and oftentimes they receive lower quality of care. And what's most startling in that analysis from IOM is that even after taking into account things like income, neighborhood, geography, comorbidities, health insurance type, some of those social and demographic factors, it still showed that among Blacks in particular, their outcomes were worse than whites. So if anything, I feel like what this really tells us is that microaggressions are this phenomenon that have a really big impact on accessing care, health outcomes, and quite frankly, deferring care because of the situation. So let's talk about how do microaggressions play into behavioral health outcomes. In 2014, Kevin et al., who's with the City University of New York, released a study of about 500 participants and concluded that racial microaggressions have negative effects on mental health for people of color, where microaggressions often stem from geography, education, race, age, and it led to the conclusion that individuals lacked trust and engagement and therefore would potentially defer their care, which therefore would lead to poor outcomes. In 2019, Nadal also released another study of about 300 participants where the majority were mid-30s females, and he was able to conclude that and correlate that these individuals had elevated levels of depression, anxiety, and chronic traumatic stress symptoms when they felt they experienced microaggressions in accessing care. And it also concluded that there was a measurable impact on morbidity and mortality among this racial minority group when compared to white Americans. When we talk a little bit about physical health outcomes in microaggressions, Nadal did a study in 2017, and he concluded that racial microaggressions were found to predict various types of physical health conditions. So specifically, pain and fatigue were areas he focused on. When you think about those conclusions, and then you layer them with what he learned in earlier and later year studies on the behavioral health outcomes, and knowing what we know through empirical evidence about comorbidities, it really does create potentially the perfect and unfair storm for people who are experiencing racial microaggressions, trying to navigate and access healthcare, develop a trusting relationship with a provider, and really engaging in their care to achieve ultimately the best outcomes that they need to have. And I'll be honest, when I try and research a little bit about the specifically physical aspects of microaggressions, it's hard to find literature or research in this area that doesn't have some kind of social or psychosocial impact involved in it. So I think this is an area where we need to do a little bit more research in the healthcare space. Shalon's story. So I think probably most of you have heard about Shalon at some point in your experience learning and educating yourself around discrimination and the impacts of healthcare. Let me tell you a little bit about Shalon. She was a part of the commission corps of the U.S. Public Health Services, where she had been a lieutenant commander. She had a bachelor's degree in sociology, 2 master's degree, and a dual degree track PhD. She had a rock solid support system personally. She was very healthy. And at 36, she was part of an elite rank as an epidemiologist with the CDC. But then the unthinkable happened. 3 weeks after giving birth, Shalon collapsed and died from complications of high blood pressure. And she, for the CDC, was the primary research working to eradicate disparities, especially on the issues of Black women who are facing disproportionately high rates of maternal mortality. Arlene Geronimus with Michigan School of Public Health had coined the term weathering through this experience, which really means it's stress-induced wear and tear on the body. And this causes vulnerabilities and increases susceptibility to infection, but also leads to early onset of chronic disease, and in particular, hypertension and diabetes. And it can even accelerate aging at a molecular level. So really, Shalon's stories has profound implications for pregnancy, the most physiological, complex, and emotionally vulnerable time for a woman. And this really shook, I think, most of our nation as a wake-up call on understanding how people, even genetically or not, have these unequal outcomes and the role that discrimination or microaggressions can play in it. So I'm going to move super fast through some of these next slides that come from the 2018 Commonwealth Fund study on reducing racial disparities in healthcare by confronting racism. Just to further my point, you can see here that a Black woman is 22% more likely to die from heart disease than a white woman, 71% more likely to perish from cervical cancer, and 243% more likely to die from pregnancy or childbirth causes. You can see here, when we look at disparities in mortality rates for Black and white Americans on heart disease, that in 1990, there was a difference of 55 per 100,000, and that jumped up to 66 in 2005. And I'm starting to see more and more literature that we're not seeing a decreased trend the way that we need to see. It's either stabilizing or it continues to show an even bigger gap. Pretty much the same thing here for female breast cancer mortality. You can see that it's almost triple in 2005 what it was in 1990. And when we look specifically here on stroke mortality, it's come down a little bit, but not enough to really convince me personally that there's a lot of effort that has taken place to change this. This slide talks about disparities in the incidence of breast cancer mortality, and you can see that it's slightly lower for Black Americans, but at a much worse mortality rate. You can see the survival rate was 80% for Black women and 91% for white women. And a lot of our research tells us that we think it's due to later stage detection, which makes me wonder what caused that later stage detection and what role microaggressions played in potentially deferred care and poor outcomes. You can see in this next slide some gaps in the completion of cancer treatment between Black and white Americans. There was a study that was done by the Racial Equity Institute showing here that if you use nurse navigators to not only help our Black patients understand the treatment and meet their social needs, that they were able to work on mistrust with the provider and really bridge the gap in some of the disparities there. But yet we're not seeing that kind of effort being taken across our entire healthcare delivery system. And this is a similar slide on colon cancer and colorectal screening rates that Health Partners, a company in the US, leveraged by sending home a home screening test toolkit for the Black Americans. And we were able to find that after 3 months of the intervention, an additional almost 800 more patients of color had been screened, and altogether that screening gap really diminished over time. So I'm moving fast with you today because I really feel like we could talk about what we've all seen firsthand, what we know anecdotally, what the literature tells us, but I feel most important, we really have to figure out how do we get to the root cause of how we break the cycle and move into a delivery system where we change what's happening, and it's been happening for far too long. So here's some recommendations that I have. We prioritize the measurement of health disparities, and in order to do this, we need to use data that really allows us to identify critical opportunities to drive health equity. It needs to be self-identified data. It needs to focus on race, ethnicity, language, and other demographics so we serve our populations the best way possible. We need to build partnerships to enable patients to play a meaningful role in developing their care plans, kind of like what we learned back on those slides around colorectal screenings when we were able to connect with patients where they were at and really help bridge the issues that come from mistrust. We need to target interventions to specific conditions that are chronic and plague communities of colors. We've got to focus on that. We can't just focus on conditions for all populations. We need to improve access to healthcare coverage. We must address the social determinants of health. And we really need to focus on this next point, which is diversifying the clinical workforce and delivering culturally appropriate care. There is no compromise there, in my opinion. We've got to make racial equity a strategic priority so that all populations, no matter your race or ethnicity, don't have the need or the feel of the need to delay their care and unfortunately receive those poor outcomes. The only other thing I wanted to say is that here from a payer perspective, we're really having these conversations and trying to get to the heart of these issues that, like I said earlier, can make people uncomfortable, but it's time. And so I'm really excited that our association and all the Blue plans, including Blue KC, are working together. We're getting ready to make an announcement here in about a week around our efforts on health equity, how we want to address all of these issues and really starting showing from a payer perspective the difference that we're committed to making. So I look forward to your questions, and I thank you for the opportunity to share with you today.
Thank you so much, Carmen. We are going to move to a community health perspective offered to us by Frankie Barrera. He is with Thrive Health Connection. He's a bilingual community prevention specialist, and he'll be speaking with us today about an inheritance of distrust, PTSD, language barriers, and discrimination for people of color when seeking healthcare. Welcome, Frankie.
Hi, everyone. This is Frankie Barrera with Thrive Health Connections. I am a HIV and STI bilingual community prevention specialist here at Thrive. I am also a medical interpreter certified by the National Board of Medical Interpreters. And I think that might give me a little bit of a perspective of what we're about to talk about. I am going to probably go a little on a different route. There's no presentation, PowerPoint presentation, or anything like that. I would like to talk to everyone on a one-to-one basis and have a little bit of a reality check for all of us working in healthcare. So it might be, some people might be getting scolded, some others might be just hearing the hard truth of what really happens out in the community. But to begin with this, I am going to talk about something, or I'm going to talk about something that everybody at least once in their life has thought of, at least for a few seconds, once in their life. We all have thought of it. I know I think of it at least once a day, which is finding out that a long lost relative has left you an inheritance of wealth beyond belief that will take care of all your economical needs and all your economical problems for you and generations to come. I'm right? Everybody has thought of that at least once. I know I have. And like I've said, on a daily basis, I do. But the harsh truth of this is that there is inheritance that not many people think of on a daily basis. Nobody wishes upon themselves or anyone else, yet they still have to carry the burden of them. An inheritance of distrust, PTSD, language barriers, and discrimination for people of color when seeking healthcare. That is an inheritance none of us actually want to carry. But guess what? It's the reality that we live on today in 2021. Yes, people, the 21st century, and we still experience all of that. From Black folks being experimented on with medication so that they could be safe for those of lighter skin, from the father of modern gynecology, thinking that because of the amount of melanin in your skin, it was the more tolerance you had to pain. Sounds horrible, right? Like a horror story. I don't know, Chainsaw Massacre. Well, that one was true, and so is this one. It is 2021, and some people may be thinking, well, that was a very long time ago. Why talk about it? Or, well, people should be getting over it. But let's fast forward. Picture it. It's 2020, September. The south border of the United States that border our neighboring country, Mexico. Latinx women being sterilized against their will, secretly getting implanted IUDs and getting hysterectomies without their consent. So this was all over the news. This was everywhere. And it was in 2020, 6 months ago. So yes, it has been a long time for some things, but it continues to happen. Imagine living with that inheritance on you. It creates inherited PTSD and distrust in the medical community. And why wouldn't it? Because this is people that were supposed to take care of human life, yet they are selecting on who and how. It's not an attack on the medical community, nor on all of us who work in the medical field, but it is a reality on how we can understand why the people of color haven't actually come to trust entirely that health system. They inherit that PTSD from being experimented on or seeing people that look like them being experimented on. They are distrusting this community because of everything that has happened to people that look like them. Visibility matters, but representation does even more. Because the more you see people like you suffering through stuff, it's the more that you are going to suffer with them. So with that comes many other parts and many microaggressions and phobias like xenophobia from people who don't speak the language. That's where the inheritance of language barriers comes. And when it comes to this, I'm going to talk about a more personal experience. I'm a first generation born in the United States, meaning that I speak English because I learned English in school. My parents didn't have that opportunity, especially my birth mother. She had not gone to a doctor in 6 years before she moved closer to me because of the language barrier and what she had experienced. I am a medical interpreter, and on a daily basis, I have accompanied people for the last 4 years to appointments that shouldn't have happened at that level. If they had the trust to go to a medical appointment, dental appointment, or vision appointment, I wouldn't be interpreting imaging for cancer because they could have taken care of that before with a simple blood test if it had been detected previously. But guess what? In 2021, still, when even the Constitution marks that English, it's nowhere marked that it's the official language, we still get all those people having xenophobia and being racist and being discriminatory towards those who don't speak the language. That is another way to discourage people from following on with their medical care. Recently, about 4 weeks ago, I took my birth mother to a dental appointment. And thankfully, she has me, who actually knows what the medical field looks like and what the medical community works like and knows how to work with the insurance. But imagine all of those that don't have it. She hadn't been to a dental appointment in over 8 years because she said that the last time that she was at a dentist, they didn't even have a simple interpreting phone service. I mean, those have been around for what, 40 years? And we still experience this nowadays. All of this just makes it harder for people to actually go and get taken care of, going to regular medical appointments, going to the dentist, vision appointments, and many more. And yes, I mean to sound repetitive. Why? Because maybe this way we will get it. Medical professionals still at their practices, not offering something as simple as an interpreting service via phone. Yes, it is tedious and it is probably not the best way to offer an interpreting service, but it isn't expensive and it's better than nothing. Yes, representation matters. Hiring those that look like the people you want to serve. That brings trust. That brings that idea that they're going to be safe and that they're not going to have to go through what their ancestors had. I work in the HIV and STI field. And let me tell you, it does make a great difference when somebody looks like the person who's going to test you. It does make a great difference when somebody speaks the language that you speak, or at least attempts to get to somebody that could understand you so that you can communicate and have the proper bridge and conduit of communication. I love how many people try. And trying is good, but doing is better. I love that people try to target those much in need, but have you ever put the thought of why are they the ones in need? there is so many statistics, but that's not what I want to bring in today. I want to make sure that people understand that today, all those phobias of people that don't look like you, all those phobias of people that don't sound like you, are simply created by a system that has been in place for so long that we have learned, and now we carry it on without even thinking if it's right or wrong. It's the reevaluation and relearning of all of this system in order for us to change and understand that not because it has been done for so long, it means that it has to continue that way. Yes, it makes me very passionate because I have experienced it with my family members. Yes, it makes me feel passionate because I am a person of color. I speak the language, and yes, I do have an accent. And yes, sometimes it's hard for me to get the words across, even though I actually know the language. Imagine those who don't. Imagine someone new coming to this country and feeling lost and continuing to be lost throughout their life because of the language. Imagine those remembering or even knowing a little bit about what their ancestors had to go through so that some people could be comfortable in their life. Well, that is an inheritance of distrust, inheritance of PTSD, language barriers, and discrimination, because discrimination looks in various different ways, from implicit bias to what actually has to, from what we actually think previously to acting. So today, I just want to invite you, open up your minds, medical providers, offer the services. And if you have any questions on how I will open all of the resources that I have as a community health worker, as a medical interpreter, to maybe help out there and help people open up those doors for those that you may not be serving, not because they don't want to be there, maybe because they don't feel represented and they don't have the trust, and it's not their fault. At the end of the day, the system has failed them over and over and time after time. Thank you.
Thank you so much, Frankie. Particularly for sharing your own personal experiences. I know sometimes that can be very difficult. So thank you so much for sharing with us. We will move on next to the researcher perspective. We'll hear from Dr. Megha Ramaswamy, who's a professor in the Department of Population Health at the University of Kansas Medical Center. She will be speaking with us today about discrimination of people involved in the criminal and legal systems and how they face that when they seek healthcare. Welcome, Megha.
Thank you, Christina. I appreciate the invitation, and thank you, Frankie and Carmen, for sharing your unique perspectives as stakeholders in this arena. So I've been working in jails as a public health researcher for the last 15 years. I design, implement, and evaluate public health interventions, mostly around women's health and sexual health for people who were leaving the system. So I want to talk a little bit about sort of discrimination that people in the criminal legal system face, both in jails and prisons and when they reenter the community. So 95% of people who are incarcerated leave. And so this is very much a community health story. And just to give you some context, 13 million people leave jails and prisons in the US every single year. On any given day, 7 million people are under some type of criminal legal supervision, whether that's in a jail, a prison, or in community corrections. There are incredible race and gender disparities, as I'm sure you well know, in terms of who gets incarcerated. 1 out of 3 Black men can expect to go to prison in his lifetime. The incarceration rate for Black women is 6 times that of white women. For brown women, it is 3 times that of white women. There's been a 600% increase over the last 40 years in the incarceration of women, owing to the war on drugs that Richard Nixon waged in the 70s and its associated policies. This is the problem of mass incarceration in the US. In terms of the health of people with criminal legal system involvement, it's a high health need population. Between 60 and 90% of people who are incarcerated have a comorbid substance use or mental health problem. 25% of all cases of HIV in the US are represented by people who have passed through a jail or prison. 30% of inmates have hepatitis C, 25% have some sort of STD diagnosis on any given day. 80% of people who are incarcerated are active smokers in the community. And sometimes if they're in a smoke allowed jail or prison, they continue to smoke there too. The people we work with in jails and prisons in the US are overwhelmingly underemployed, underinsured, and undereducated. In Kansas City, only about 50% of the women we work with have health insurance. Nationally, only about 50% of the people who are incarcerated have a high school education. And I work with women specifically, only between 1 and 30% nationally have full-time employment upon leaving incarceration. The encounters with healthcare vary in terms of sort of the population of people with criminal legal system involvement. For any jail or prison, the healthcare budget accounts for the largest portion of the overall budget for those facilities. As I've said, people who are incarcerated have complex, chronic, and infectious health conditions. And I'll just say a word about the difference between prisons and jails. So prisons are for people who have been sentenced to a year or more for their crimes. Jails are holding facilities for people who are awaiting sentencing or trial or who have been sentenced for a year or under typically. I work in jails because they are very much community entities. There's one in almost every county. And I don't know if this, I guess this is a Kansas City audience. You might notice the jail if you're driving on the I-70 overpass. It's at 1300 Cherry. It's a red brick building with slats for windows. Any big city, you see a building right in the middle with slats for windows, you know that's your city or county jail. And I think that jails are compelling sites to work in because this is a population of people who are moving in and out of communities. And there's lots of good public health work we can do during that phase of transition. So in terms of prisons and jails for that matter, most healthcare is administered by large healthcare corporations. In fact, there's only a handful of these in the US that provide the majority of care in these facilities. For the most part, these healthcare corporations treat symptomatically and not preventively. So in the jails, they're not doing things like routine STD screening, routine HIV screening, any sort of cancer screening. If you show up with a problem, they will treat you. And of course, you have to pay to get treated in jails. I think the one sort of nice thing about healthcare in jails and prisons is that it is essentially universal care. So as I'm telling you that 50% of our population doesn't have health insurance, a jail or prison is the one place that women can reliably get care that is to some degree paid for. There is a huge question about quality of care. So in jails, there is always a copay model. So inmates in our Kansas City jails end up paying $5 for a visit. Now, bear in mind, this is an extremely poor population, and the $5 copay depends on whether or not a family member put money on your books. So not everyone has that money. And in fact, the jails will run a tab for you that then you have to go pick up the cost for, when you leave. The quality of care is highly variable and depends on who is administering that care. What is the attitude of the individuals? Do they truly care for patients? And then there's the question of whether or not patients are treated as patients or if they are viewed as criminals or viewed in the context of their crimes. So some examples here. 23 states in the US still shackle a woman during childbirth if she is coming from incarceration. I have a colleague at KUMC, Dr. Jason Glenn, who did a study of medical residents who work in prisons, and it's not uncommon for those residents to cast their incarcerated patients as malingering, that is, having a psychological orientation to disease, pretending they have a disease when they don't. And these same medical residents, it seemed, were not taught that they should not consider the person's criminal record. So when we go into a jail, we always train our research staff, don't ever look up a person's criminal record if you find out their name. don't think about the crimes they've committed. In fact, we don't even ask what a person's charges are because they're not relevant to the research that we're doing around sexual health. And similarly, when a clinician is treating a patient, knowing a person's crime is simply not relevant. But what Dr. Glenn and his student Sierra Stites have found is that medical school and residency curricula rarely teach trainees to take into consideration not only the many health and social vulnerabilities of this population, but also to teach them simply to separate the sort of criminal aspect of their patients from the work they're doing as healthcare providers. Quality of healthcare in these settings is influenced, as I said, by the provider, the healthcare administration model, whether it's a partnership with the university, a partnership with the county health authority, or a partnership with the medical care corporation, as well as the bureaucracy of requesting and receiving healthcare. So what practically has to happen in jails is a patient has to submit a sick call request. And they either do this in an electronic kiosk or they do it on a slip of paper. And you can imagine in these underfunded county institutions that the kiosks and the papers don't always work, that they're not available. It's at the discretion of the CO, the correctional officer there, to be able to give an inmate access to this way of requesting medical care. And then there is no telling when a nurse is going to show up to take the inmate from the holding cell to the medical side of the jail. In the case of the facilities we work at. And so much of the sort of bureaucratic nature of actually requesting healthcare remains a challenge for inmates. And you can read about inmates in the popular press, delaying care, bleeding out, passing out in their cells as they wait for critical healthcare. So correctional officers and jail and prison staff often have a profound influence on the care people receive while they're inside. So a few years ago, we ran an intervention in the jails 5 days long. We did this over a period of 2 years with about 200 people, 200 women, where we talked about women's health and sexual health care. We brought in nurses as part of our team. And so often the inmates loved the chance, not only to just sort of talk about anything with trusted outsiders, but also the chance to talk to a clinician because there were nurses on our team. And so any number of health issues they were experiencing, they'd run it by the nurses. And we had a case where I'm no clinician, so I don't know the significance of her diabetic episode, but she had expressed some clinical concern that was related to her diabetes and had asked, could the nurse on our team talk to the jail administration to see if she could speed up her medical care because her medical care request hadn't gone through. So we said, are you sure? We're happy to do this for you. My colleague, Pat Kelly, went and told the jail administrator, hey, could you please see this patient? I'm a clinician. This does not look good. And we come back 2 days later and find that the woman has not received healthcare, but has instead been sent to solitary confinement for complaining. And so that was not a clinical decision. That was, a decision based on the part of jail staff because they didn't like that this woman complained. And so that is the kind of thing, that happens, not sort of uncommonly. The other sort of healthcare that this population experiences is healthcare in the community. And this is much more the area of sort of my expertise. Jail leavers are high utilizers of healthcare. 50% of the women and men we work with have been to an emergency room in the past year. 25% of the people we work with have been hospitalized overnight in the past year. And another 50% have seen a primary care clinician in the past year. We have tried and found that it is really difficult to talk about healthcare discrimination based on race. And I think that's because we haven't gotten very good about talking about racism with our participants. But what we do hear a lot is discrimination based on people's drug use. So our women sort of know which doctors in town, which clinics will not judge you based on the track marks on your arm from injecting drugs. And we always sort of have the opinion that women are the experts of their own lives and that they can sort of help each other find the best healthcare outlets in any given community where women will not face that kind of judgment. We also found that women have a great trust of the nurse practitioners associated with their OB care, their obstetrics care when they have babies. 80% of our women have children under the age 18. And so those nurse practitioners have often been with them for years and years and a number of babies, and are often a trusted source of care that can help bridge, one healthcare episode to the next. We also, and Christina sort of spearheaded this work. I was like, why aren't you presenting? Why am I presenting on this? We had started hearing as soon as I came to Kansas City and was working in the jails that don't go to KU, which, full disclosure, my husband does work in the ED at KU, but don't go to KU because you will get arrested. And I thought that was sort of curious, but we heard it from women, we heard it from men, we heard it from Black men and white men, that this was simply not a place to go in the community. And we never heard that about other hospitals in town. And so Christina, as part of her master's thesis, sort of started digging into this work. And what she found, I asked her permission to share these data. She did this study I think in 2015. So in the year 2014, 123 people who were booked into the Wyandotte County Detention Center were arrested at the KU Medical Center. We are, I think, one of the only hospitals in Kansas City that has a state police force. We are heavily surveilled. And as I'm sure you know, there's a whole literature on sort of why we have that level of surveillance and nurse and physician fear about violence in that setting. But I think the surveillance and the criminalization of regular patients showing up to an urban ED, a trauma center, is pretty stark. And Christina is not the only one to have this finding. Alice Goffman wrote this fabulous book called On the Run about the surveillance of Black men. And she documents how, I think the study was done in Philly, how police officers would stroll by the OB-GYN ward and look at the visitors' logs to see if any of the people who had open warrants were in those visitors' logs, and then would go arrest them as these young men were visiting, the mothers of their babies. So, this kind of surveillance happens in healthcare settings, and people who get wrapped up in the criminal legal system are very aware of what hospitals are safe and what hospitals are not, and will actively avoid those hospitals. And as public health practitioners, we help disseminate that information. Right? Even though KU is happily my employer, this is not a safe place in terms of, this very specific population for a number of reasons that Christina and I have tried to dig into. So here are some sort of high level conclusions. Obviously, this is a population with high health need, as well as high healthcare utilization. It is also a population of people who experience any number of race and gender disparities associated with their incarceration. And that what I have talked to you about today is less about microaggressions, but much more about systemic aggression. These are aggressive criminal, legal, and healthcare policies and safety policies, so-called safety policies. And I think that while certainly more work should be done on how people with this kind of criminal legal system involvement experience microaggressions, there is a dearth of work on that subject. I think that it's really time to be thinking about the systems as aggressive themselves. Thank you.
So much, Megan. I think a lot of times when we talk about things like phobias and isms and microaggressions, we tend to navigate towards race and gender issues. And I think incarceration and experiences with the criminal incarceration system are also an area where folks experience discrimination as well. So we are going to pause for just a second and see if there are any questions or comments for our speakers who have shared their expertise with us thus far, or any that are coming up. This is a safe space. I know when talking about things like these topics, folks can feel a little hesitant to ask questions, but that's what we're here for, is to learn. And so please feel free. Stacy Farr, who is a research assistant professor at the University of Missouri, Kansas City, and our leadership with KCTVIC will help facilitate this session for questions. Please don't be shy.
Sure. So we have a few in the chat box, but if anyone also has one that would like to speak, you'd be welcome to unmute yourself and ask now. But otherwise, in reading the chat, there's a question.
Well, I have a question. This is John Spurtis. All the speakers, by the way, have given fabulous presentations, and I really appreciate it. And as a sort of white male who is oblivious to a lot of these issues, I really appreciate all that you shared. And, as one who's sort of very interested in trying to figure out what actionable steps could we take to address some of the problems you raised. I mean, we have the good fortune of having an amazing group from throughout the community who are very involved in healthcare and trying to improve the value of healthcare and trying to address some of these issues. What would each of the speakers say would be steps 1, 2, and 3 to address some of the challenges they raised?
I'll go real quick. I mean, that's a really heavy question. And I think that there's much more that we need to do than what I can respond to briefly. What I will say for myself, both as a person, from a personal standpoint, as a white woman, without some of the lived experience that so many of my friends and neighbors have, and as a professional in a work environment, which so happens to be healthcare, I need to respectfully be willing to bring these questions up and identify when we have opportunities to think differently and challenge the way that we address these issues so that we can really be driving towards greater equity for everybody that we're serving or living with. So I feel like that's the first thing. I think the easy thing to do is to ignore it, whatever the issue is, or to not speak to it because it's uncomfortable. And then I think the second thing is to get involved in taking action and doing it in a productive way, doing it in a way that really shows that you're moving in addition to the questions that you're asking and showing support for making changes.
Hi. So, like Carmen was saying, I don't think there is a 1, 2, and 3 and so on steps to make it better when it comes to, bridging those gaps. But there is definitely steps that we can take as a society. One of them, I think, it's like I've mentioned, representation. Representation matters so much to everyone. I think empowering those in the community of communities of color, making sure that they feel empowered to actually follow career paths that can lead to other communities, feeling more comfortable in our health system. That would be a great step for us to take, empowering all of those young people out there that we know in our lives to fulfill their dreams to become whatever they want to become in the medical system. When it comes to the language barriers, it's really simple. There is the services available. They are somewhat inexpensive and somewhat necessary as well, because some people have paid insurance for years and they have never used it. And I don't know, I know Carmen works in insurance, but that's something that you can also bill their insurance for. So I feel like that offer a service where people can actually have a proper bridge and conduit of communication. And lastly, and very important, is acknowledge your own bias, your own, those subconscious discriminations, microaggressions, and phobias that you may think that are not there, but analyze your actions before actually doing them. Make sure that when you're asking, you're not asking with a judgmental tone, making sure that you're hearing not only with your ears, but with your eyes, with your senses, with, listen to your gut. If you think that it might not be the right thing to question, that might be good as well. And lastly, when it comes to sexual health, because I am a sex positive advocate, and that's what I do for a living here at Thrive, be open-minded about the fact that not everyone's experience has to connect with yours, so that they could continue to go and follow up with care in many, many, many other ways.
Great, thank you, Frankie. And I know, Mega, you commented in the chat, but I'd love to hear your words on it as well, aloud.
My formal response is in the chat, and then I got carried away with my husband's medical school friend. But I think sort of the other thing I would add in sort of reflecting on what Frankie has said, I have this great project director, Joy Whitcliffe, and she goes into the jail. She, runs many of the sessions, and she always starts the sessions by saying, this is a no judgment zone. So to Frankie's point about just being sort of open to what you see and non-judgmental and being explicit about that, right? Like, this is no judgment, do what, be who you are. And then I think I did mention in my comments, we also have this thing we say that you are the expert of your own lives. So tell us, how it goes, right? You are the expert. Let us hear you say what the solutions are and how you see the problems and how you construct the problems. We do interventions with a critical health literacy framework that very much encourages people to question status quo assumptions about gender, sexuality, race, and health. And that's very much a part of the interventions we do, is to get people to sort of question both authority, but also the way things are.
Great, thank you. And then I haven't read the details of it, but I would also, just like even at a higher level, thinking through some of the like policy level changes that could be happening. I did see that yesterday there was a House bill that was introduced. It might have passed, but it was essentially to kind of look at how we can undo some of the effects that we have seen through slavery for African Americans. And so I think, that's another level by which we can consider some, bigger systemic changes as well. But these are all really great strategies. And anyone else have a question they would like to ask to any of our speakers? Otherwise, I'm not sure where we were at in the agenda and how much time we have left for the first Q&A.
I have a quick question for the speakers. Are there any resources, this is Todd Moore, is there any resources or books or manuscripts or publications that you would recommend for folks to just to punch into real quick? And I know sometimes that's real quick is not the right phrase, but something that folks can refer to if they wanted to have additional information, something you found to be inspirational, anything.
Good question.
Dr. Ramaswamy, will you just talk about those authors real quick? I appreciate you typing them in.
Yep. So Carmen, I appreciated referenced Arlene Geronimus. She has this weathering theory. I think that is an important theory in this work. Nancy Krieger writes a lot about racism, and data right now is something she's very interested in. So if you pull up her articles, they're pretty great. There is a woman who runs the first Center for Anti-Racist Research and Healthcare, Chandra Ford, Chandra Ford. She's someone to follow. There is a woman I love in Minnesota whose name is completely escaping me, but I'll send you her name later. Oh, I know, Rachel Hardiman. She works on Black infant mortality. She is fabulous. And then I was just typing, but you made me stop. Dorothy Roberts and anything on radical reproductive justice. And Frankie might like this perspective too. It's about moms and babies, but I think the radical part will resonate. And there are people who are writing in sort of a sex positive space, but Dorothy Roberts and others are writing in sort of a reproductive health positive space that stems from Black feminist thought and is pretty beautiful and community embedded.
Also, I would recommend, there's a book by Paulo Ortiz. It's an African-American and Latinx history in the United States. It lines up the Latinx history and Black history as well, and how they were both fighting for things that were so meaningful to each without knowing that they were fighting actually for the same causes, to be recognized and to be viewed by society as equals as their white male counterparts. So I think that's a book that opens eyes very wide to those who really don't see how communities of colors really struggle throughout history. I think that would be a great book for people to actually read.
That's such a wonderful question. So from a research perspective, I'm working on this book called Race After Technology by Rua Benjamin, and it talks about how automation has the potential to hide, speed up, and deepen discrimination while appearing neutral when compared to racism in like previous eras, and then decolonizing methodologies. I've actually heard folks from other population groups look at this book, but it's about research in Indigenous peoples by Linda Smith. And then from a healthcare perspective, when looking at how Western medicine sometimes is at odds with other cultures and spiritualities, When the Spirit Catches You and You Fall Down is an amazing book about how the failure to go outside of your box can really have negative outcomes for people of different cultures. So I will type those all in the chat as well. Any additional questions before we move on to our next speaker? Okay, we'll have another session for questions and answers. But next, I'd like to welcome Dr. Michael Weaver. He is the Medical Director of Equity, Diversity, and Inclusion at St. Luke's Health System. He will provide a healthcare perspective, and his title for his talk today is St. Luke's Health System's Journey with Isms, Phobias, and Microaggressions. Welcome, Michael.
Can you hear me?
Yep.
All right. And can you see my screen?
Yeah.
Excellent, excellent. Wow, well, great first session, and thank you all inviting me to talk about such an important topic during such a reflective time. From a social justice standpoint, let's see if I can get this full screen. There we go. You know, dealing with George Floyd and all the social inequities that are going on, and all of the inequities that have been that have bubbled to the surface, that have been going on for ages with the COVID pandemic. I think this is really an important topic. Obviously, it's a very, very complex topic. And what I want to do is specifically focus on the part of healthcare that has to do with healthcare disparities. And some of our speakers have already talked about this and given excellent presentations. So I'm going to make just some brief comments about the isms and phobias and microaggressions in healthcare, identify their connections to bias and how bias connects with healthcare disparities. I think those are really important dots to connect. And then just make a couple of comments on some national healthcare programs that try to address bias through patient-centered care and education. So as has been already commented on, you know, everybody knows about racism, sexism, in terms of the isms, and certainly in terms of the phobias, homophobia, xenophobia. These things have already been touched on earlier. But again, these aren't things that are new. They've been going on for many, many, many years. And microaggressions have already been discussed as well. This term initially coined back in the 1970s by a Harvard professor looking at how Black students at Harvard were treated, and he talked about the indignities and insults against people who are marginalized, typically on the basis of race, but also gender. And then when you apply these microaggressions to healthcare, this alienates and marginalizes patients and can actually also alienate and marginalize clinicians among themselves. And so, you know, just a couple of simple examples here. Someone that's LGBTQ that's interested in AIDS research or working on an AIDS floor or something like that, you know, they say, well, you know, that makes sense. You're gay, you would be interested in this. Or a woman who wants to be an orthopedic surgeon and having someone say, well, you know, women aren't usually into that. Why are you doing this? This isn't normal. Wasn't what we expect. Or just looking at female physicians, right? And having them mistaken as nurses. And I can share personally as an African-American physician that I've been mistaken as an orderly or someone in housekeeping if I wear scrubs. So, you know, I make sure that, you know, I wear a tie. I don't just wear scrubs. And again, all of these, I think, are really rooted in what we're talking about today and sort of coalesce around bias. So I put this slide in here not to scare everybody, but just to say, you know, there are all types of biases, right? Both conscious and unconscious. And, you know, at the end of the day, it's just the way our brains work, right? It's part of our lived experience. It's the tapes and the grooves in our brain circuitry that develop over time. Again, the lens that we see the world through. So, and especially if you're in like in the emergency room, right? Stress adds to biases, right? Because this automaticity pops up. When you have time to think more deliberately and make more rational judgments, then you don't do these things that happen out of automaticity. But again, it's important just to recognize, and you know, good, bad. I have a biases, you know, for the Chiefs against the Raiders, but it's the root of many of our human behaviors, and it drives these isms and phobias and microaggressions. So as I said, I want to focus on the healthcare disparities piece, and I like this definition by the Institute of Healthcare Improvement as a difference in healthcare outcomes between groups within a population, whether just or not, as opposed to healthcare inequities, which brings in the unjust portion of it. But again, you know, these have been around forever. And we used to initially focus on, well, you know, it's a problem because they're poor, or it's a problem because they lack health insurance, not poor, but can't afford health insurance. Or it's all about their educational level, all of these proxies. And of course, more recently, we've said, you know, it's about where you live. It's about your zip code being the most important predictor of your health. And then now we know that there are not only social determinants of health, right, but there are structural and political determinants of health. Just socially, we kind of focus on access to care, but all of these things interconnect, and they're all historic, and that's part of the race and structural systemic racism. So again, we've got to really appreciate that this just didn't happen overnight, although so many people now, because of COVID disparities, are going, oh wow, really, this going on? But these things started with bias, and they've been perpetuated by bias. So it's been hiding in plain sight, and already the comment has been made about unequal treatment. You know, so this goes back to 2002, right? An incredible volume of healthcare disparities that were published, and I just have to. There are a few I just want to touch on, right? So this was published in the New England Journal of Medicine. So they hired Black and white actors and gave them the exact same script to go into doctors' offices and say, I have chest pain radiating down my arm. And they found that African-American females with the same symptoms were less significantly likely to be recommended for cardiac catheterization. Why should that be? Exact same symptoms. VA study, African-Americans 33% less likely to get cathed, 44% less likely to get angioplasty, 54% less likely to get a cabbage. And again, you know, is this socioeconomic? Is it because they're poor? Well, this was a VA hospital, so they all have health insurance. So it's not about that. Why would that be? It's already been commented earlier in terms of, and you know, sadly, the healthcare has been complicit with these issues of Black people having different pain receptors or thicker skin and all that. And this is in my domain as an ED physician. Study done 2 different locations in Los Angeles and Atlanta, where Black and brown people with the same fractures were compared equally. And it was like, why was it that Black and brown people got less pain medicine? Black children, looking at opioid pain administration for appendicitis, 40% versus only 21% of Black patients. Moving forward, already been talked about, pregnancy rates. Why should it be that African Americans' mortality is 4 times that of European Americans? Why should that be? And so it was interesting, back in 2002, that book said, although it's complex, it's multifactorial, evidence suggests that bias, prejudice, and stereotyping on the part of healthcare providers may contribute to these differences. Now I could fast forward today and I could show you, I mean, the literature is just replete with biases that medical students have, that nurses have, that residents have, researchers have, the publishers of our journals that we read have. Why should that be? Again, not just gender and race. Look at weight biases. 2,000 medical doctors found that overall doctors show a strong implicit bias against overweight people. Gender bias. 50% more men than women were recommended for knee surgery with the same sorts of knee arthritis injuries. But why were they recommended for surgery more often? You know, there's a bias. When men got to get out there and work, right? So the question comes up, should we treat everybody equally? Well, that doesn't get to biases. That's sort of like, you know, I don't see color. And that's actually considered another microaggression, right? When somebody goes, well, you know, Mike, I don't see color. But all people are not the same. You do want them to obtain their full health potential and have quality outcomes. That's health equity. You want to treat them with respect. You want to treat them with care that is culturally and linguistically competent and congruent. And we all want care that is patient and family-centered. So it's not about equal treatment. It's about equitable treatment. And for providers, for clinicians, it's about quality outcomes. And I'm sure some of you have seen, or many of you have seen this slide. And, you know, I kind of think about it, this difference between treating people equally versus treating people equitably. And, you know, the first slide here with everybody getting the same amount of support, but realizing that they're different people. And boy, can you apply this to COVID, right? I mean, you know, in Black and brown communities, you need to be more resources like the middle slide to those patients to get equitable care. And then obviously the hope is that you decrease those disparities. And then I'll just share, I mean, a lot of national programs. I do like this from the Joint Commission because they talk about advancing effective communication, cultural competence, and patient and family-centered care. And what they tie together, I think, for the healthcare community, and you just got to make this connection between quality, safety, and equity. I mean, it really all comes together. The hospital associations, 1, 2, 3 equity pledge, saying that has been already commented earlier, that we will collect race, ethnicity, and language data and slice those to make sure, and follow those and slice those and make sure that people are getting equitable care in our organizations. That will increase cultural competency training. And again, they focused on this when this first came out, but clearly this applies to health literacy. Clearly this applies to unconscious implicit bias training. I just can't emphasize that. That's my point here. Advancing diversity in leadership and improving and strengthening community partnerships. I like the Health Equity Index. This is sort of like the Joint Commission for LGBTQ care and looking at healthcare disparities for the LGBT community. Again, just another important overarching national program. So I would just, again, my point is to take these isms, phobias, microaggressions, and say they are really all rooted in historic biases that have led to these structural and systemic issues that we're dealing with now in terms of healthcare disparities. And I would encourage all of you, those of you who haven't, to please take the implicit association test, very well validated Harvard tool. And you can look at and find your own bias. That's kind of the first place you want to start, right? You can find your own biases. And it only takes 10 or 15 minutes. You can find out if you have gender biases, if you have racial ethnic biases. And I think it's important for the healthcare community to really focus on giving all of us in the healthcare industry training to understand and mitigate biases. So thank you.
Thank you so much, Dr. Weaver. Our next speaker is Sandra Thornhill. She is a volunteer and social media coordinator, as well as a member of the Community Expert Review Board for Uzazi Village. She will be providing the patient advocate perspective, and her talk is called Uzazi Village and the State of Black Maternal Health. Welcome, Sandy. And it appears that you are still muted.
Hi. Today has been a day. Thank you so much for your all's patience and allow me to have flexibility with your agenda. My name is Sandra Thornhill. I do serve as social media and volunteer coordinator with Uzazi Village, as well as a founding board member with the Community Expert Review Board. Today, I come to talk to you all about Uzazi Village, about the work we do, about the programs we have, as well as I want to uplift this moment to celebrate Black Maternal Health Week. And that's why I am tardy to the party. Uzazi Village was being recognized by Kansas City, Missouri City Council for our work in Black maternal health care. And so we were getting a special actions recognition right now. And just like city politics work, sometimes meetings run behind. So I'm here now and I'm happy to be here with you all. Thank you all for joining this conversation, this important conversation about inclusivity. And that's really the crust of Uzazi's work. It's a part of Uzazi's work is making sure that we are building a safe space for our Black and brown birthing persons. And I use that word, that phrase intentionally, because we understand and recognize that not all of our Black birthing persons may identify as women or things of that nature. And so that's one way in our language and in our training, we are trying to dismantle phobias and to be inclusive and to uplift the intersectionality of reproductive justice as a whole. So Uzazi Village, for those who are not aware of, we are a nonprofit organization physically located on the Missouri side, but in this last year, we have expanded to a physical location as well, a second location in Kansas. We do work to improve the health outcomes for Black mamas and Black babies and Black birthing persons. And so our vision is that for every village, there's a healthy, for every baby, there's a healthy village, and for every village, a healthy baby. And so we serve that vision through our mission to impact and improve Black maternal health care, as well as infant health care. In our city alone, in Kansas City, our numbers and our stats are horrible as it relates to the outcomes for Black mamas, and even worse for the outcomes for Black babies. And so through one of our longest running program, our doula program, we help combat that by making sure that there are Black and brown advocates standing with our birthing persons in the delivery room, preparing for labor, after labor, in the 4th trimester, during the postpartum area. And so our doula program is the first program for Uzazi Village. It came together from the community, seeing what was going on in the city, recognizing that our Black and brown mamas were dying at horrific numbers here in Kansas City. And that vision birthed the idea for our co-founder, Hakima Tafuzi Payne, who's also our CEO, and the other co-founders to find Uzazi Village, to organize Uzazi Village, and to train doulas, to train Black and brown doulas to serve the Black and brown community. Now, from our doula program and Uzazi Village starting several years ago to the point that we are now, we've grown, and we've had a chocolate milk cafe. That was a program started by Uzazi Village, and now is its own 501c3. That program services Black mothers specifically, and gives us a space, gives Black mothers a space to have a safe space to talk about breastfeeding and the wonderful blessings and everything about breastfeeding. Uzazi Village also trains doulas. I am a trained Uzazi Village doula myself. Recently trained this last January and February season. So we train Black and brown doulas to serve our community too. We also have a lactation consultant services outside of Chocolate Milk Cafe, where mothers and feeding persons can come and get support outside of what they will receive from, what they will or won't receive from hospitals or their care provider. And so we fill in that gap and provide some culturally congruent and culturally relevant support for our Black and brown birthing persons and feeding persons as well. So beyond that, beyond our core mission work, Uzazi Village holds an essence and a space, a safe space for Black and brown families to commune and be in community with one another. Now, COVID-19 has definitely challenged us to be unique and be creative in how we hold that space. But we have been able to continue our work through things such as our diaper drive. We hold a diaper drive on a weekly basis where families can come and pick up diapers, food, equipment for their little ones and for the birthing person. We also host a closet boutique once a month where families can come into the building, social distance on a schedule appointment to come and grab whatever items they need: clothes, maternity clothes, infant to toddler clothes, equipment such as beds or car seats and things of that nature to hold them over, because this is a tough time. If Black and brown maternity care wasn't tough before COVID, COVID has definitely compounded that need and the great need that our families have. So we're finding ways to work around to stay safe and to support our families at the same time. In addition to that, through initiatives such as the CERB, which I'm a founding board member, that's the Community Expert Review Board, Uzazi Village is engaging with researchers so that we can be on the front end of understanding, or on the front end of research, so that we can engage with researchers to know if they're causing harm, how they can interact with our community, what does safe interaction with our community look like, and to really stand as warriors between research, good and bad research, basically. And so through the CERB initiative, we're able to also engage in policy work, research and policy, understanding policy, advocating to policymakers, such as what we did last May to City Council saying that, hey, Black families are suffering in disproportionate numbers with COVID. We need you to do something about it. So that's some of the work that the SERP has done. The SERP is also doing work across the state line with consulting work with the CAB of Kansas on the Kansas side. And the SERP also came out with a report about how hospitals, how Black birthing persons are faring in hospitals regarding COVID. And our report was based on the time frame of January to like March. So we released a report about that. And you can find all of the information about a report about the SERP on Uzazi's website. Another initiative of Uzazi is food sovereignty and food justice, as well as farming and planting and gardening. So we have a garden initiative where our gardener has a grieving garden for mamas and for birthing persons. If you've lost an infant due to just the traumas that are happening. We grow herbs in our garden, maternal herbs that can support our families and their needs. We also sponsor garden plots across the city, in the urban gardens across the city, where families who want to grow their own food, healthy food that can support their maternal process and feed their healthy baby across the city. And so through our garden initiative, we are expanding and really speaking into the reproductive justice, tenets of the reproductive justice movement, and hopefully impacting and improving the lives and experiences of Black birthing persons. And so that's just a few things that we do at Uzazi Village. And I started off as an Uzazi mama when my son is now 2.5 years old. And I'm so grateful and thankful for coming into presence of being in that space, because through that space, I've come to find and identify my voice as a Black mama. And I've come to identify my voice going out into the reproductive justice world and understanding what food sovereignty is and understanding the economic, disadvantages or barriers that impact my health as a birthing person. And so this gives me a good transition to go to what I'm most excited about right now and this week, and that's Black maternal health. This week is Black Maternal Health Week. This is a week to raise awareness for those who wasn't aware, because a lot of our Black mamas, Black babies, and Black-led organizations who work for Black mamas, persons, and babies, we've been doing this. But if the nation wasn't aware, we are raising awareness by proclaiming that we're going to take a moment to pause and celebrate Black maternal health. But we're also going to take a moment to realize that the United States has come a little way, but we are bottom of the barrel as it relates to the health outcomes for our pregnant persons, period, but especially for pregnant Black pregnant persons. And so we want to bring awareness and elevate this issue to a national level so that we can see some legislative change that will trickle down to be change that happens within our research institutions, change that happens within our hospitals, and change that's going to eventually uplift and help our Black mamas and Black birthing persons have thriving experiences in the maternal health care field. So I'm excited to celebrate Black maternal health as a Black mama. I'm excited to celebrate Black Maternal Health Week as an advocate for birth justice. And I'm elated to celebrate Black Maternal Health Care Week as a reproductive justice advocate as well. So I invite all of you, if you haven't already, do tune in to Black Maternal Health Week. It was founded and is being led by the Black Mamas Matter Alliance. You can check them out online and see all of the wonderful events that they are sponsoring, as well as tune into Uzazi Village's social media and see all the wonderful events and activities we have going on too. Last but not least, I want to give a call to action. It's great to have these moments to come and hear things and to speak with one another. But my call to action for you is not only to get plugged into Black Maternal Health Week and the Black Mamas Matter Alliance movement and Uzazi Village and all of these other wonderfully Black women-led organizations in Kansas City and the region, but also take this message to your communities, take this message to your organizations, to your families, and talk to them about the significance and importance of celebrating Black maternal health, and invite them to join in this mission to make a difference and make a change. So that's what I wanted to come to talk to you all about. There's so much more we can continue to talk about, but I would like to yield the floor to the question and answer portion that we have coming up.
Thank you so much, Sandy, for all of that information. I have so many questions that I will let Stacy facilitate the last few minutes that we have. I know we've got some questions in the chat as well. So Stacy?
Sure. So in the interest of time, we only have 1 minute. Do we want to, anyone want to call out any final questions? Otherwise, I think it would be great to hear there was some good conversation about access to care and the now quadruple aim, or the previous triple aim. If there's any comments you wanted to make on that, Dr. Weaver.
I guess I have a question for Ms. Thornhill. Do you feel like the political and social tide is changing and that people are much more keyed into these issues? Or is it sort of, same as 2 years ago, 5 years ago?
Oh, no, I definitely think the tide is shifting. Within the last 4 years alone, Black Maternal Health Week is in its 4th year of celebration. And between this time, we've had things such as the Black Healthcare Caucus in Congress be founded by Congresswoman Adams, as well as Congresswoman Underwood, and then Senator Harris, now Vice President Harris. Out of that caucus, we've seen the Momnibus, which is a package of bills specifically packaged together to address Black maternal health care. The White House this week, the White House for the first time ever has had introduced a proclamation to recognize Black Maternal Health Week. So there is a tide, there is a wave happening right now. And this is a moment for us to take advantage of the political environment that we have. Like I said, Vice President Harris is one of the founders of the Momnibus and introducing the Momnibus. So this is a moment for us, and we definitely should capitalize on it and ride this wave. So great question.
I would dovetail on that and just tell you all, this is a great book by Daniel Dawes on the political determinants of health, because ultimately, as Sandra was talking about, that's where you talk about really making change at the structural level of our politics and incentivizing the right things in the healthcare industry.
Sandra for Senator.
Agreed.
And Sandra, I will probably contact you offline, but I'm very interested to see if you, how your community, I'm gonna mess up your acronym. Your community expert review board has been able to engage with researchers and what kind of projects are being proposed through that board. Because I know that there's great connections between the folks that are on today.
Definitely.
Yes, and feel free, for those who have my contact, feel free to share it out with those who need it. So I'm definitely open to that conversation.
Thank you.
Great. Well, this was an amazing, amazing session, highly informative, great speakers. It's so good to hear different perspectives from everyone. And that's why we really enjoy these forums so much, to hear the voices of everyone and different organizations and the way in which they're tackling, approaching, and how we can all learn together and grow together. So thank you so, so much. And just so everyone knows, these are recorded and available later on our website. So if you know someone who wanted to hear but was not enabled, they can visit our website, kcqvic.org, and it'll be up there within a few days. And thank you all so much. We appreciate it.
Thank you.
See you next month.
Thank you.